here's what I'm going to do. I'm going to go. This is me, and again, thank you for having me here. And I do think that, like with a lot of topics, really getting into the basic science of it and understanding it really helps you understand the clinical science. So I'm going to go through a bunch of sort of semi-related topics that are really understanding the underpinnings of pharmacology. Then we're going to go over the cases that you just raised and other issues. Again, this will be reviewed for some might be over your head, and I know everybody comes from a different place. So these are the topics I'm going to try to cover, at least as it apply to understanding the pharmacology of fentanyl, buprenorphine, and all opioids to some extent, and why they do what they do, and why when we're getting into the syndromes associated with overuse of buprenorphines, they really become very complicated. Everybody recognizes this is just an image that I get from a weekly New Jersey Department of Health or some equivalent, actually Department of Justice, I think, a document that I get, and it just shows the analyzed opioid or heroin specimens that they get for the past couple of weeks, and you can see here that virtually no sample of heroin doesn't contain fentanyl. And in fact, there are some samples of heroin that contain no heroin and only contain fentanyl. And then they contain various other things. 4-AMPP is a precursor. You'll see tramadol in there, xylazine, which is another sedative that's often added. I think everybody's seen this picture or a picture like this, and it really very nicely encapsulates the issues we're dealing with. And it just shows you that the lethal dose of heroin compared to fentanyl, compared to carfentanil, we'll talk a bit more about that in a moment, are dramatic. And when you get to drugs like carfentanil, which have extraordinarily high potencies, it becomes very difficult to dose because it's so hard to know how much you're taking. But this is really representative of the issue we're going to talk about today. But potency is really important because a lot of people use the word potency to mean how much of a given drug do you have to take to have an effect, right? And that is part of what this would suggest. But there's also a concentration in the blood effect of potency. And that's usually what we're talking about when we're talking about the potency of a drug. So here you see two drugs at different potency. In other words, the drug B takes a much higher dose to get to the same effect as drug A. So you'll say these drugs have different potencies, but you can see that the ultimate effect of the drug is the same. It just takes more of the blue drug to get to the same place that it takes the red drug, but ultimately they both get there, right? And this could be measured in either dose taken or concentration necessary. Most toxicologists, most pharmacologists are really talking about concentration, but most people on the street are talking about the actual dose of the substance you need to take. And we'll come back to that, I think, as we go on. But potency doesn't really matter, right? And here's just an example of how different the potencies are of different drugs, because you can easily overcome potency by just taking more of the drug. Right? So we know, for example, that that heroin has got 4 times the potency of morphine. You just have to take 4 times the amount of morphine to get the same effect. And you can say the same about fentanyl. If you take 100 times less fentanyl, you get the same potency as morphine. But ultimately, fentanyl is much more difficult to dose, so it's easy to overdose. Again, potency is a relatively unimportant concept because it's easy to gain. When we get to other things, it becomes a little trickier. We talk a bit about efficacy. And again, the folks that are well-schooled and remember their pharmacology know that efficacy means how much of an effect you can have when you get to the maximal dose of that drug. So you'll see that a full agonist, now some of these full agonists may not hit their maximal efficacy till you give extraordinarily high doses. But a full agonist, for example, like morphine, as you go up and up and up in the dose, you'll get increasingly continuing effects. Right? So we know that with morphine, if you give a little bit, you'll get a little sedation. If you give a little more, you'll become unconscious. If you give more, you'll die. Right? And that's because the full agonist effect, when you hit full efficacy, happens to be measured in respiratory depressant effects and ultimately lethality. Partial agonists, of course, as you can see on the diagram on the right, have a maximal efficacy. Right? And they vary based on what sort of partial agonists they are. And you can see that their efficacy is only 50% in this case of the full agonist. Some of them are more potent than others. So you can see partial agonist B requires much lower dose to get to the same place as partial agonist C, but ultimately both get to the same efficacy. of that fixture. An antagonist, of course, has no efficacy. It binds. It can bind quite tightly, and we'll talk about affinity next, but it has no efficacy. It doesn't do anything to the receptors, blocks it. And there actually are chemicals, we don't see many of them, that are inverse agonists, that when they actually bind, they have a negative effect. They actually do the opposite of what the agonist of that drug does. Probably the one that most people are familiar with is flumazenil, right, which is an inverse agonist at the benzodiazepine receptor. Okay? So it's not just an antagonist, but it's actually an inverse agonist. Actually has the effect of unbenzodiazepine, unsedating you, if you would like that comment. But affinity is important too, and these two concepts come back as we go further into this, because they combine to really describe the effect that the drug ultimately has. So the affinity of the drug for the receptor is how tightly it binds, and that how tightly it binds is a make-believe term, because nothing really binds tightly. What it really represents is how much time of a given period of time that drug spends bound to the receptor. So if you look at the equation on the right, drug, receptor, there's a back and forth, an equilibrium between R and AR. Right? So a drug that has a very high affinity like buprenorphine spends more time in the AR state than it does in the R state. Drugs that have lower affinity, for in this example methadone, spend more time unbound than they do bound. Realize Ki is measured in such a way that the lower the number, the higher the affinity. Now, affinity plus efficacy equals response, and that's that equation that I think people have to remember. So something that's got high affinity but not very high efficacy isn't going to have much of a response, and vice versa, right? And that's where fentanyl is going to come in as we move forward. I just want to talk for a bit about half-life, right? Because I think a half-life is another concept that people sometimes misinterpret, only because we're used to thinking about half-life for most drugs in terms of that first dose that we give them, and then the elimination of that dose. So if I give you a dose of fentanyl, it's got a half-life of about 19 minutes. So if you wait several half-lives, there's none left in your body. So 19 times 5, it's about 100. There's going to be no fentanyl left in your body after about 100 minutes. And you can see for morphine, it's about an hour. Hydromorphone, which is dilaudid, the same. Ignore the methadone one for a minute because it's a slightly complicated concept, but you got to look at the terminal elimination. Like, this is how long does that drug last ultimately in your body, right? So it first distributes into some space, but then it gets eliminated from the body, and that's the terminal half-life. Fentanyl's terminal half-life is actually fairly long, right? It's measured in many hours. Even though the initial effect is very quick and it gets into the brain and out quickly, it leaves the body over a very long period of time, as does methadone, right? And that's why methadone has a half-life of over a day, right? But what's important is if you look at the bottom figure, fentanyl, as you give it, either for a longer period of time or multiple times over a period of time, builds up in the body. And its half-life actually prolongs, as does methadone. For many drugs, no matter how long you infuse them, the half-life stays about the same. They're flat, morphine, hydromorphone. But you'll see fentanyl and methadone, their half-life increases with the amount of exposure you have. In this case, it's an infusion, but in a person who uses fentanyl several times a day, it's really the same, just onloading into the body. And the reason for that, and here's a quick example from the literature that'll show you nicely that in people who use fentanyl on a regular basis, their half-life prolongs, their duration of effect, you'll see, can last for many, many days. And you'll still be able to measure it. And of course, it will still have an effect on the receptor during that time. And the reason is because of its lipophilicity. Right? Drugs that have high lipophilicity like fentanyl, and lipophilicity is measured by the octanol water coefficient, octanol lipid, water, right? How well it partitions into octanol versus water determines its lipophilicity, right? So you'll see, for example, a drug like fentanyl has a very high lipophilicity, right? When you take it into your body, it partitions into your fat and then leaches out over a long period of time. That's why with the single dose, your body fat has very little in it. With lots and lots of prolonged infusions or many doses, your body stores in the fat are very high. You'll maintain a steady state blood level from the leaching out of the fat into the blood for quite a long time. Lipophilicity has other effects too, and I just show you on the bottom, which is it's a rat study, but it's a cute study. This is the first pass brain level in a rat after given an IV dose of morphine, codeine, which is methylmorphine, heroin, which is diacetylmorphine, and methadone. And you can see that it's essentially directly proportional in terms of brain uptake to their lipophilicity. Right? That's why heroin gets you high. It gets into your brain very quickly because it's fat soluble. Morphine doesn't get you high. And that's why nobody abuses morphine. And that's why the cartels go through the process of converting morphine from the poppy into heroin. If they tried to sell morphine on the streets, nobody would buy it. Right? And of course, it does explain why fentanyl is a great substitute for heroin, because it gets into your brain very quickly because it's got a high lipophilicity. Just as another example of lipophilicity, which I like to show, I think everybody probably knows that intravenous intranasal cocaine are usually given as the salt, whereas smoked cocaine, free base, or crack is given as the base. So it's not charged, whereas the salt is charged. So you can see on the left-hand diagram, if you give an IV salt, you get very high plasma levels. And on the right-hand side, you get a lot of intoxication. You get a lot of clinical effect. But if you put it in your nose, because it takes a long time to get into your body, you get an adequate blood level, but it doesn't make you very high. Whereas if you smoke the base, or if you smoke crack, even though your blood levels don't go up very much more than if you use it intranasally, it gives you as much a high as the IV use of the drug. Right? And that's because the base isn't charged. It's lipophilic. It crosses the blood-brain barrier much more quickly, and it's much more intoxicating. And you can take all the social justice and other issues out of the equation. Just pharmacologically speaking, there is a difference between salt form of cocaine and base form of cocaine, and this is really what the difference is. I want to talk for a moment about tolerance, desensitization, and withdrawal. This is an image that has to do with alcohol, but I like it because it's a little easier to understand. I'll show you the example of what happens with opioids in the next slide. But if you just look at this, for the naive alcohol user, they drink and they have a little bit of a GABAergic excitation, a little NMDA receptor inhibition, which is the red on the right. That makes you intoxicated. Of course, when it goes away, you're back to baseline again. But as you continue to drink, your GABA receptors desensitize. So the alcohol has less of an effect on them. And because you're blocking the NMDA receptors, the glutamate receptors, they upregulate. Right? So desensitization of GABA, upregulation of NMDA. Right? As long as you're exposed to a normal, for you, amount of alcohol, you're at baseline, but that's your new normal. Right? Once you stop drinking, and you either, in this case, you become abstinent, or with an opioid, maybe even you get an antagonist, you can see that you lose those effects, leading to withdrawal, right? Which we know as autonomic instability. We lose the inhibition that alcohol has. We lose the control of excitation that the NMDA receptors are undergoing, leading to overexcitation and withdrawal. Right? And it's a little easier because only two receptors involved here: the glutamate receptor for NMDA and the GABA receptor, obviously for GABA. This is a little bit more complicated because there's many different effects going on with opioids. And I'm not going to spend time talking about this. This is mostly just to show you a pretty picture. While I just say that when you bind to an opioid receptor, there's effects on the receptor and its desensitization through signaling, uncoupling, receptor internalization, and other things that ultimately lead to the development of tolerance, right? Meaning you need increasing doses of the drug to get the same effect. I think everybody recognizes that. Tolerance isn't really the problem. Tolerance is easily overcome by giving more drug. Right? The problem is, as in in the case of alcohol, developing tolerance is a new normal baseline. It's when you lose that new normal that you withdraw. And that's basically what happens here as well. Multiple mechanisms and much more complicated. I do want to talk 1 second about this because it does lead to some interesting insights. Differential tolerance. So we know that there are different opioid receptor subtypes, and opioid receptors in different parts of the brain. We also know that when you start using opioids and you're getting euphoric from them, there's a parallel increase in respiratory depressant effects. And they really do parallel each other, as does sedation. Right? Over time, you develop more tolerance to the euphoric effect than you do the respiratory depressant effect. So what you'll know is that as you push the envelope to get higher and higher doses to get high, you will cross the respiratory depressant threshold, which hasn't really developed any tolerance, and you'll stop breathing. That's the problem, of course, with opioids, is as you push the dose, full agonist, eventually you're going to continue to get high, you're going to stop breathing. Right? And that's the problem with differential tolerance. If the tolerance developed equivalently to the respiratory depressant effects and the euphoria, there really wouldn't be a problem with opioids. You wouldn't die if you increased your dose, as long as you had tolerance to it. But because tolerance doesn't develop equally, it leads to respiratory depression and death. Of course, precipitated withdrawal, which Dr. Perone just talked about, is important. And this is just an example from a journal to save me from drawing it out. But here you're looking at something, for example, like buprenorphine coming in and knocking the opioid out of the receptor, right, leading, of course, to precipitated withdrawal. I think we recognize that we're replacing a full agonist with a partial agonist, and that's leading to a relative reduction in the opioid effect, and that's leading to withdrawal. The treatment, of course, for buprenorphine-induced withdrawal, precipitated withdrawal, is to give more buprenorphine. Right? And the reason that works is because of what we've talked about before. Buprenorphine has a high affinity, but the more you give, the more buprenorphine is sitting around the receptor, able to bind to that receptor as another molecule gets off. Right? It's the same reason, in a way, why a person with a high tolerance for an opioid can still overdose. Right? They still can, even though they have their receptors fully covered by opioids, the on-off kinetics of that opioid allow, when more opioid is present, more opioid to be bound to that receptor. Right? And that's the same reason why an increasing dose of buprenorphine is able to quell buprenorphine precipitated withdrawal. You could give an opioid to do that, but you'll remember that buprenorphine's got a much higher affinity for the opioid receptor than any opioid that we could possibly give that person. So that buprenorphine is going to effectively keep that receptor clean from most of the opioids we provide to people. So this whole idea, of course, at the bottom, which I think maybe you've had a chance to look at, is the idea of microdosing. Rather than just giving a big dose of buprenorphine and knocking them off all at a time, you give a small dose and you slowly withdraw the primary opioid over several days, allowing you to slowly develop slowly lose your tolerance to the full agonist opioid while maintaining the tolerance to the partial agonist. And microdosing, there's a lot, we don't have to talk about that here, other than I think to recognize that there's a lot of ways to do it. Some people maintain the primary opioid while they're up dosing the buprenorphine. Some people titrate one up and one down. Right. Another way to do this, and I don't know if Rachel Rose is on the line, but in a way, this is a somewhat newfangled, but I find it to be an incredibly useful technique from the emergency department. Now, what they do in Camden is a little different than what I'm going to talk about. But in Camden, when the paramedics administer a dose of naloxone and they precipitate withdrawal, now obviously that's an antagonist, knocking all of the opioid off and not providing a partial agonist in its place. Right? They precipitate fulminant opioid withdrawal, much more severe than the opioid withdrawal you get from a partial agonist like buprenorphine. But what they then do is give a large dose of buprenorphine, which can, because it's got a high affinity, knock the naloxone off the receptor and keep all the opioid off the receptor, right? And in a way, this is like macrodosing, right, as opposed to microdosing. They're taking somebody who's been given this large dose of naloxone and is now in withdrawal, and they give them a big dose of buprenorphine right up front. Now, we've taken this a step further, and I realize in these cases they give naloxone, they give buprenorphine. There are papers you'll read about of people who give naloxone intentionally just so they can give the buprenorphine, which I find to be quasi-ethical. And what we've started doing is actually just giving the big dose of buprenorphine to people who don't have opioid withdrawal yet. I remember, if you think about it, if you're going to give a small dose and when they precipitate, you can give them a big dose, why not just give them the big dose right at the beginning? And we've had great success with that, although I will admit I haven't published any of it yet. But I think maybe we can use that as a jumping off point to have a discussion, if you'd like, and see what other people think about some of those ideas, because some of these are newfangled. You know, microdosing is only a few years old. Macrodosing may be the first time you ever heard of it. Let me stop sharing. I'd love to hear what other people think, or if anybody has any experience or opinions.
Yeah, that was totally perfect. I think that's a lot of what we wanted to hear as a foundation for the conversation. So that was great. There are some conversations in the chat. Ronnie, who is a primary care, but doing buprenorphine clinician, asked about microdosing and for home induction. I'm sorry, the chat moved and now microdosing for home induction or only done in the hospital. And then Maggie, also primary care addiction medicine, talked about doing some microdosing and strategies. I don't know, Maggie or Ronnie, why don't you ask your questions to our whole group?
Well, I guess my first question with the macro dosing is, it seems I did it one time in the outpatient setting for someone who was really struggling and had precipitated and called in a panic. We actually had just had a recent speaker right before who had talked about it in this forum. And I was like, let's just try it and see what happens. And we did it, and it actually worked really well. And I guess, I mean, one question is, do we think that macro dosing over time is going to become like the new standard for induction? And should we be thinking about it more in our patients who are so afraid or have experienced precipitated withdrawal in the past, just to get through that? And then the same thing with the microdosing. I had heard about it in another forum, but it was all inpatient, where they were still continuing them to treat their pain or whatever else, and then doing like 1 milligram. And I had seen it every few hours, but I think that was because it was in the inpatient setting, so I wasn't sure how much was being done in the outpatient setting with that.
Yeah, I think microdosing in the outpatient setting is challenging. It's a complicated process that involves 0.5 milligram for 2 days and then 1 milligram for 2 days. You got to cut strips or cut tablets, or so I think it's a lot for most people to comprehend. So it's usually done in the inpatient setting, and it's primarily, I think, done for methadone conversion. You can use it for anybody, but because that tends to be the most difficult one. Although I'll tell you that one of the things I was going to raise was the idea that fentanyl becomes essentially methadone when used on a regular basis, right? Again, that single dose of fentanyl is up and down and it's gone. That chronic use, because of the fat solubility, makes it just as long-acting as methadone. Remember, the problem with methadone isn't that methadone is such a potent, terrible agonist. It's just that it lasts for so long. You have such deep dependence from that chronic exposure to it. You never are free from methadone when you're on methadone. When you take heroin, you got heroin goes up, heroin goes down, heroin goes up, heroin goes down, right? When you take methadone, you take it and it just stays there, forever. For days, right? With fentanyl, it goes up and goes down until you start using it a lot, in which case then it starts becoming steady state. Then you develop this deep tolerance. Then you need to microdose them off of fentanyl. You can't just give them a dose of buprenorphine anymore as if they were using oxycodone or heroin on an intermittent basis.
And the macrodosing in fentanyl, would that be effective, or you think microdosing in the chronic fentanyl user is the better way to go?
No, I will tell you that we've had some pretty good experience with macrodosing. right? And we've taken people on methadone, and even 90 or 100 or 120 milligrams of methadone, and with a single big dose, we've actually converted them in one dose to buprenorphine. We've done it as an inpatient, to be fair, mostly because we kind of had read about it, and we knew, and we have other colleagues out in California who've done this and whatnot, and it was in the OBS unit actually, but we didn't just say, here's a dose, go home. But now it's become our standard in the emergency department to start people. We start people who have COW scores of what amounts to 0 on buprenorphine that way. Because if you wait for the methadone user or the heavy fentanyl user to get a COW score of 8 or 13 or whatever, it could be hours to days before it happens. That means you have to do a home induction or bring them into the hospital and keep them there for a while. So our go-to drug in the ED, we're not doing that. We're going to give you a big dose, usually 16 with a quick escalation to 24 and occasionally 32, right? And well, I'll tell you that we've probably done it, I don't know, 15 times maybe. All but one of them were very clean. One person had some precipitated withdrawal, but we treated that with an escalating dose. And it wasn't that severe, honestly. It was done in the inpatient. But now in the emergency department, we've switched to pretty much just starting people on big doses. Whether they have, we don't usually dose people who aren't already in withdrawal. That's just, most people don't want that. I mean, it's something that you'd wind up doing in an addiction clinic where you have a relationship with a patient. People don't come in asking for that. Although there have been times that we've discussed doing it and have done it. Not that just a couple of weeks ago, actually, I did it in the emergency department, and it works. It works fine. Microdosing you can't do in the ED. That's really got to be done in an inpatient or through an outpatient, very tightly controlled outpatient setting with the right patient. Long answer to a hopefully question.
That's great. I know Maggie, Joe, and Kit may all want to comment, but Maggie, maybe you could talk a little bit about your strategies in your Bupe van patients. You're on mute.
Oh, yeah, unmuted. Yeah, I shared the link to the paper that I sort of used to do this protocol. I mean, I do all outpatient, mostly sort of low barrier mobile van-based treatment. I see Joe's on here too. That's exciting. I know you do that too. And so I had a patient, most of the patients are like heavy fentanyl users, so we struggle with all these same things. And this was a patient who was really struggling with really tolerating, even with some comfort meds, like tolerating any type of withdrawal. So I did like exactly the protocol sort of that Dr. Nelson described, where it was very, very low, and I had to work with her to cut strips actually into, I think, 0.5 milligram pieces, and then we sort of over the course of a week cross titrated. She just used as much heroin or fentanyl as she thought she needed. And actually, she felt like it was really revolutionary, and she tried to get on buprenorphine multiple times and tolerated it well. She was somebody who had a phone and was able to communicate. And I mean, I think it would have been harder to explain in many of my patients who are a little harder to track down. But I think in the outpatient setting where I think, or especially at home where I might be more nervous to try like a true macro dosing approach, it was really good. And I did share the protocol. It was the case report that actually she sent to me a while back, and I basically followed that protocol.
Absolutely. I mean, if you have a compliant patient who, is, educated and well connected and, and has a lifestyle that allows it, there's no reason you can't microdose at home. I would not macrodose at home. Right? Yeah. I wouldn't say here's 32 milligrams, go take it when you get home. I would do that in the emergency department. Yeah, I would agree. I would do that. But the idea of home induction, I've always, we've tried it. I guess a little bit has to do with your patient demographic and how good you are at spending time talking to the patient and making them understand what you want to do. But you say, go home, wait till your COW score is X, 13, whatever. Most people just can't do it. I find it really challenging to get people to wait. So we've stopped doing that for the most part.
So I just to ask a little bit more about that, because we do almost all home inductions and actually have been pretty successful. And maybe it's because they're engaged. We meet with them a lot. We have core. They have lots of support. But I guess the question in terms of the concerns with macro induction at home, they're given the week's supply. Is it more of you're afraid they're going to take too much, or like what would be the fear or concern of doing that in the home setting if it's someone who you have lots of contact with, they're established in your clinic, you can reach out, they are understanding what's going on.
Yeah. I guess the way you phrase it, I don't have a real concern, except with methadone, I think it's a little more unpredictable what's going to happen, and maybe with fentanyl use. I would say this: I would feel more comfortable with it as time. I will feel more comfortable with it as time goes on. Right. So as I said, 15 times or so, we've done that sort of macro dose from methadone. We don't have legions of experience with it. We don't have 10 published double-blind trials looking at it. It's sort of, I keep saying newfangled or innovative or whatever the word you want to use is. So I don't feel like I fully understand the implications of doing it. And also, the way I know my patient in the emergency department is not the way you know your patients in the clinic. These are largely unknown people to me. I mean, some of them I happen to have seen 100 times, but they're still unknown people to me. I don't have that relationship with them. So it might be different.
We don't have a lot of methadone conversions in our outpatient home induction setting. It's usually a lot more heroin, but the heroin here there's been so much fentanyl, the cocaine and the heroin now that it's almost like everybody has some fentanyl in them to some degree. And I've had more and more issues with them getting to what you were talking about, to that chronic state where they're in steady state and they wait the 24 hours plus and are like, I didn't have symptoms and I took it and I precipitated withdrawal because I thought I was so far out from my last use. And so as I'm getting their initial urines, I'm like, do I need to think about these patients differently if I see that fentanyl in their urine? And should we be thinking about changing some of our strategies a little bit?
My answer to your question is,
happened a couple of times.
Yeah, my answer to your question is everybody's on methadone today. Right? Meaning fentanyl, right? Everybody doing a buprenorphine induction on is being inducted or induced from methadone, right? Because that's what fentanyl is when you use it in high doses. That's why it's so challenging to do. Compare how it is to somebody who uses heroin or oxycodone to how it is to somebody who uses fentanyl or methadone. They're two different patient populations.
Do you think dose matters? I mean, I think it has to matter, but I mean, for Ronnie's patients, maybe some of them are using fentanyl that they're buying on the street that's pressed fentanyl and, has some oral oxycodone versus, somebody who's really doing, 3 bundles a day. I mean, I'm seeing a lot worse I guess, risk of precipitated withdrawal or risk of severe withdrawal symptoms in the higher dose fentanyl patient population. I think it makes sense, but.
No, absolutely. I mean, the thing that's probably most proportional to withdrawal is dependence. And we know the thing that's linked most to dependence, of course, is dose and chronicity and, area under the curve, essentially, of drug use, right? More potent opioids tend to induce less tolerance and dependence, believe it or not. But if you use them a lot, they generate worse dependence and tolerance. But otherwise, all otherwise equal, low potency opioids actually generate more tolerance because they cover more receptors in order to get the same effect, right? More potent opioids cover fewer receptors compared to low potency opioids, so the tolerance dependence seems to be less. But when you cover the same number of opioids with a high potency of receptors with a high potency or a low potency drug, the high potency drug is going to produce more dependence and tolerance. So functionally what we're seeing is people using high doses of high potency drugs causing tremendous degrees of dependence, which is why the withdrawal syndrome is so complicated and difficult to treat. That makes sense? Yeah, that's why if you understand the pharmacology of it, it kind of comes together pretty nicely overall, I think.
So I guess some of the questions I still have, I mean, it might be easy to give 24 milligrams of buprenorphine in your ED, but it is a little challenging to draft, system-wide protocols for things that lack an evidence basis in a health system.
Agree.
So I do know that there is a paper, Lewis and I know about, a colleague at Highland Hospital in San Francisco is going to publish sort of a case series of 1,000 patients who have gotten really high doses of buprenorphine. It isn't all in patients using fentanyl, but it is, the strategy to getting people. Oh, that's weird. Getting people, onto buprenorphine. So that might give us some, published experience that will be able to help us.
Yeah. I mean, to your point, it's taken us a long time to get EDs and people to accept buprenorphine, period. Right. And now we're trying to get them to go from, why don't you just use 2 milligrams, let them smell this strip. And now we're saying you got to give them 32 milligrams. You can see why there's some resistance. And I'm hoping that over time, people will learn that this is the right thing to do.
Yeah. Kit, you've been quiet, and I know you're a huge advocate and have done a lot of.
Yeah, it's good. I haven't really thought super deeply about the pharmacology, but I think this makes much more sense for me because I've done a lot of bupe inductions, and I found that I've had many cases like the one you described at the beginning with the chronic fentanyl user who has precipitated withdrawal after 8 milligrams. And I think by sort of trial and error, I've now, if I see that, I immediately give them 8 to 16 more, like within the next 20 minutes, and then it's fine. And so that's been my general approach. But I did have a case of someone that was kind of resistant to trying to be induced because it had similar experiences like that in the past. And I was working with Nicole, our certified recovery specialist, and said, well, why don't you try microdosing this patient? And we gave that patient 2 milligrams, and they're like, oh my God, like I'm still okay. And, and so we sort of started at a lower dose. The challenge, I agree, is like, how do you continue that? And sort of, and we don't really have the grip, unless like, the best way, like beyond the ED, for them to sort of like slowly escalate their doses. But yeah, I agree. Like, I think that for these people who are like taking, 8, 10, 15 bags a day for several days, like you have to start high, or else you're just going to precipitate withdrawal. Right.
But remember, so buprenorphine was introduced in an age of heroin, right? Not an age of fentanyl. It's a different world. I also think, it is what it is, and it was studied the way it was. But in a way, one of the big disservices that occurred was using a 4 milligram starting dose, right? Because that's the wrong dose. They should use 0.5 milligram or they should use 16 milligrams. Right, but using that middle dose is just enough buprenorphine to knock enough morphine off heroin off the receptor to make you withdraw, but not enough to block that withdrawal. Right, so either you have to give tiny doses and microdose them, or big doses and macrodose them. But that middle dose is the wrong dose.
Yeah.
And I see Joe wrote a comment about convincing people to take bupe again. I think that's a big deal because once they've had that feeling. It's especially because it's voluntary. It's not like somebody walks up to them on the street and pushes naloxone in their nose and they don't have a choice. They're taking a drug on their own free will, under the assumption that it's going to be safe. And once they precipitate, you've kind of lost the ability to get them back.
Yeah. And just to follow up, I think on Rachel and Joe's comments in the chat, I think because a lot of the protocols, in our health system too, are like our clinical decision support says, if they have a COWS of 8 to 12, start with 4, and then if it's 12 or more, start with 8. And so for like the person that just got waivered and is just sort of following the protocol, they end up having this experience and then sort of like, they're not going to, do it anymore. And then the patient sort of has this bad experience. And then, like Joe says, it's like hard convincing patients to try bupe again. So I do think, like, even though we're sort of waiting for the evidence to come out, we may need to get the word out more on, like, okay, for the patient that's using heroin, which is essentially fentanyl, which is essentially methadone, you have to start here or microdose, But for the people who are taking like oxycodone or other things, like it may still work. But I think we're just going to run into this problem doing a lot of precipitated withdrawal in the current state.
Right. There are two populations of patients. There's heroin users, which don't exist, and oxycodone users, and hydrocodone users, and then there are people on fentanyl or methadone. And this would be true for fentanyl patch and all the other low-level but chronic fentanyl users.
And Joe just put a question in the chat. After day one, what dose do you put them on? I think is the question.
16, and then we would titrate, but usually it's over the hump, and then they just stay on 16.
Yeah.
Can I ask a question about maintenance dosing in the era of fentanyl? I'm curious, I find a lot of people, there's resistance to doses above 16 milligrams, or insurers or this is a discussion that comes up a lot. And I wonder, given what you said about sort of, high use and high tolerance and things like that, I frequently go up to 24 milligrams in my patients, and I feel like that's, appropriate based on the literature, but get a pushback for that sometimes. I'm curious what you think, what you would say to that.
The pushback is based mostly on ignorance, not based on an understanding of pharmacology or addiction. I guess you can make the argument that if somebody's glucose is 600 and they're taking 20 units of insulin, you're not going to say, I'm not going to raise the insulin level. You're going to give them more insulin. It's the typical analogy we like to make to diabetes, but it's the truth. Like if the person it's a little different, I guess, because you can't measure withdrawal in an objective way like you can blood sugar. But I think that you have to do what you have to do. The risk of giving a full agonist opioid is very high. So if this were methadone and you continue to escalate the dose, we recognize that a certain percentage of methadone users are going to overdose just therapeutically, and not to mention the complicated with pharmacokinetics of methadone and everything else. Buprenorphine isn't like that, right? It's got a pretty predictable clinical effect. Even in opioid naive people, while it might make you sedate, it's unlikely to stop you from breathing and make, and incapacitate you. It will definitely have an effect on you. But in these folks, you can go up to pretty impressive dose, because remember that efficacy curve has a ceiling. And, efficacy is what you call it. If efficacy is respiratory depression, it's got a ceiling. If it's euphoria, it's got a ceiling. If it's sedation, it's got a ceiling. So here, the respiratory depression ceiling is all that really matters, right? And yet, its effectiveness on treating withdrawal doesn't seem to parallel its ceiling effect on respiratory depression, right? Kind of the differential tolerance idea that I showed you before. Not every effect of an opioid responds the same way to chronic use. For example, constipation never goes away, right? You could be on an opioid for 100 years and you're still going to be constipated, right? So there's no tolerance to that, whereas there's some tolerance to respiratory depression. So I don't know if that's an adequate answer, but it's an explanation, and kind of appealing to their intellect. And I don't know how well that works.
Maggie, if you guys don't mind making a little comment here about that, I think Lewis is absolutely right. I think they nailed it right on the head, that like the higher doses are oftentimes required. But I think more frequently what I see is that people are they're taking a full strip in the morning, and then by like noon or 2 o'clock, they report that they're having withdrawal symptoms. But in reality, what they are is more cravings. Like people are feeling anxious, they start sweating the more they think about it. It almost like is a somatic thing that they create that goes along with their cravings. And that's really a psychological thing rather than a physiologic. And certainly the psychologic can lead to this physiologic feeling of it. And it sort of goes along with someone who's like gets on nicotine replacement. You don't suffice the oral fixation that people really need. And so like someone will like chew on a pen or something like that when they're trying to quit smoking. And so actually splitting up their doses, the split dosing is pretty effective in this manner. And I oftentimes have patients who say, hey, I've been taking 3 a day and I ran out of medication, and then they're seeing me and I have them just split their dose, and that just completely satisfies their need, and they do much better just on splitting their dose, like taking 4 milligrams 4 times a day.
Hey, Joe, not everyone knows who you are because this is a pretty thin crowd.
I'm from Temple. I am I'm Jean Marie's clone over at Temple. I'm EM, toxicology, and addiction medicine. And I work in an outpatient office. I run a mobile unit in Kensington where we prescribe buprenorphine, and I run an inpatient addiction medicine and toxicology unit at Temple.
But yeah, and I agree with you, Joe. I think that there's some value to doing that, to splitting it. Pharmacologically, though, there's no reason that that should be. And I think you've highlighted that.
Correct.
Pharmacologically, the drug should not have a midday lull. It's got a half-life of over a day. It shouldn't be a problem.
And so actually, I use that to explain to patients, like, look, this medication is going to be around for 24 hours, so there's no way you're going through withdrawal. So what you're likely experiencing is the psychologic portion of it. And I try not to downplay it at all. I actually highlight that that is a huge portion of addiction treatment. It's not just the physiologic, like the receptors, which we're talking about here. A huge portion of it is the psychological management.
I agree.
Yeah, it's a
I
great
think
point.
that makes a lot of sense. I was just also going to add, like, what I often hear in the pushback, sorry, I'm kind of jumping back, but is that, oh, like the receptors are like mostly saturated at 16 milligrams and that pushing the dose doesn't have greater efficacy. And it seems like that isn't certainly true in my clinical experience. And I guess, like, I'm sort of curious from a toxicology standpoint, like the response to that. But I don't need to like derail us too much on technical stuff, but that's kind of where I was coming from.
Yeah, no, I think the answer has to do with what I sort of tried to highlight, which is if you look at a PET scan that shows occupancy of receptors, it means that there is an opioid in the vicinity of that opioid receptor. But that opioid only spends part of its time bound to the receptor, right? So the more you put there, the more likelihood that receptor is going to be bound at any given time. So if you just think about it, just think it spends half its time on and half its time off, right? If there were two of them, they'd each spend half the time on, half the time off, and statistically, I don't know, that might be 2/3 of the time it would be bound, right? There's some competition. And if you put 10 of them there, it's going to be more likely that there's going to be binding. And it's going to be a, not a linear response. It's going to be I'm blanking on the term, but a nonlinear response. So there won't be,
Asymptotic?
Yeah, no,
Asymptotic?
yeah, it's not exactly, it's blanking on the name. But anyway, but it's not linear, but it's going to approach in a curved linear way. But I think that it's very clear that if I give you a big dose of heroin, all your receptors are covered. But if I give you even more heroin, you're going to die. Right. So one of the reasons, the analogy I always like to use is methadone, right? So we know that 20 or 30 milligrams of methadone is all anybody really needs to not withdraw, to not crave, and to mostly have the receptor saturated. Yet we put people on 100 or 120 milligrams of methadone all the time, right? And the reason and they don't die, right? Because they develop tolerance. Now, if you put them on 120 milligrams right away, they're all going to die. But one of the reasons we do that is because it blocks the effect of opioid use, right? So if I now take a highly potent opioid, if I take fentanyl or meth or heroin, and I inject it, there's going to be so much methadone coating those receptors that the heroin isn't going to really have an opportunity to bind, even though it's more efficacious at the receptor than the methadone is. Right? It's a little different with buprenorphine because there's blocking effects as well, but it's not due simply to bulk blocking, but it's due to affinity blocking because buprenorphine has the highest affinity of all the opioids we have. Right? It's even got a higher affinity than naloxone does. Right? So that's why we use such high doses of methadone. You don't need it, right? And that's the same thing that Joe just said. If you miss a dose of methadone, you really shouldn't withdraw. There's a ton of catastrophizing that goes on and all of that other stuff. It's a big psychological burden to miss a dose. But because it's got a half-life of 24 plus hours in most people, you have a long way to go from 120 milligrams down to that 30 milligram dose that will treat everybody's withdrawal. So if you came in and withdraw from methadone, if I give you 10 or 20 milligrams, I should quell your withdrawal. I won't prevent you from shooting up or using heroin and getting high again, but I will block your withdrawal because your receptors will be functionally covered sufficiently to stop withdrawal. So this has been studied, and we know that 10 milligrams IM, 20 PO will blunt all withdrawal from methadone, no matter how high your dose of methadone is, because that extra dose above 30 is all about blocking. Right? It's not about anything else. Right?
Maybe I can jump in here. Rachel had a question in the chat. Rachel's been leading an effort to help with a lot of our patients with high fentanyl use when they come into the hospital for another painful issue, and we're trying to stabilize their background opioid use and then treat them for pain. And we get into lots of problems around thresholds and respiratory concerns from nursing staff and really just high doses that nobody's comfortable with. But we had promised to talk to Joe about this at some point. How do you translate bags of fentanyl to doses of methadone or other opioid agonists in the hospital setting? Maybe Joe, if you want to talk about that, because that seems like something that you're doing.
I've got this like little magic 8-ball that I shake sometimes and I look inside. I think it's super difficult. I think there's a lot of nuance to it. And if I take my knowledge and I go to Dr. Nelson's hospital, and it's totally off. I think it's neighborhood to neighborhood, block to block. The supply is different and the answer is different everywhere. So like my knowledge of what's going on in the surrounding area around Temple, I think is pretty good, but I couldn't do that in Wilmington, Delaware. And it's just from clinical experience. And so what I commonly see, though, here's I guess some points that you can use no matter where you are, is once you get comfortable with understanding how much drug is per bag, not just using the total dose. Like I think that's the first question everybody wants to say, like, well, how many bags do you use a day? And for the person who's living on the street from bag to bag, panhandling for their next bag, some days are good and they've got lots of money, and some days are thin and they don't have a lot of money. So their dose really varies a bunch. And so asking questions more like, what's your get well dose or what's your wake up dose? When you're sick in the morning, how much do you need to feel normal again? I think is a better question than your total dose per day. So I look at those.
And what do you do with that information?
It just gives you a gestalt of how much you're going to need to get that person out of withdrawal. And so when someone says, "Oh yeah, I can just use a bag a day," I'm not worried at all. But I had a patient just the other day tell me he needed to use 12 bags in the morning, and he uses 3 times a day, and he uses 12 bags at once. I knew that my typical dose that I had been treating people with is not going to work. And so like just putting that person on, 80 milligrams of OxyContin was never going to suffice.
In the hospital.
In the hospital, yeah. So that's what I'm sort of thinking, like in the inpatient setting. I got to say though, my dosing should probably change in the outpatient setting when I'm having people on buprenorphine. But I think the biggest issue is the insurance ramifications. Like I can't just write for 32 milligrams in a single day. Like it's never going to pass. And I would have to be really particular with a patient about, okay, well, I'm going to write you for 5 days, but really it's only going to be for 3 days because what you're going to do, it's just that it gets too complicated.
Well, it's 5:15, and I'd be happy to chat with Louis longer. I don't want anyone to feel obligated to stay, but I think this has been a fantastic discussion, and I really appreciate Dr. Nelson's time and all of your intense engagement in this really important topic. Maybe we'll get all of our case series together and throw something out there to be published so that we can refer back to our sort of combined experience. Certainly we've all done enough precipitated withdrawal at HUP that we could get the records on 10 or 15 patients and the successes and the adverse events. So thank you, Dr. Nelson. And I know he put his contact information up on the last slide, but if anyone wants to reach out and didn't catch that, you can, I don't know if you want to tell them, or you can certainly email me.
No, thank you, and thanks for having me. It's a great group, and I appreciate the questions. I wish we could have gone through all of them, and hopefully I don't leave anybody hanging. But thank you for having me.
Great. Lots of people saying.
All right, bye
Thank
all.
you. Thanks so much.
Joe, if you're hanging around.